for standing on this novel therapy.
Thank you very much. This is a very interesting point of view. Up to now, some years ago, we could not prescribe like omalizumab for ABPA in cystic fibrosis, but over the years there were some studies that were performed, and finally we can prescribe omalizumab. In some cases in our center, and ABPA is a quite difficult situation for these patients, and with all this disease and diabetes, we have quite a lot of restrictions in order to give the right medication. So in some cases, even with omalizumab, the first line is to give steroids and like itraconazole or azoles, and if we don't succeed to treat the patient, then we try omalizumab. Unfortunately, we have some cases that even with omalizumab, we don't have the results we want. And we have tried other biologicals in our department, but our results are quite preliminary and I cannot have or express right now. Yeah. I think in some years from now, we are going to have more studies on that. Yeah.
So, obviously it seems that the battle against ABPA is in fact the battle of CF itself. When we regulate and correct this basic effect, everything will go for the better. If no other questions, I will conclude this session, and thank you very much for attending. And
thank you very much.
Nice to meet you. You will train the session? No? No. He couldn't come. Okay. And you will chair the session. Okay. Ясно за мен. Помагате ми, що да правим.
Good afternoon. So we're going on to the next session. I would like to ask Dr. Iulia Pagiu from Romania to give her talk on the management of pediatric candida infections.
Okay, first of all, thank you for the opportunity of inviting me here. Today, my name is Iulia. Today we will discuss few information about basically our activity or our situation from the Eastern Children's Hospital in Timișoara. We wanted to point out this specific activity because we are a hospital with a specific panel of activity. We are the biggest from our country, from Romania. We are the biggest bone marrow transplant hospital center. We are the reference hospital for 16 countries from our country for the surgical intervention, pediatric surgical interventions. And of course we have section ward of palliative care and oncology ward also. So let's say we wanted to point out this because we have a lot of high risk of infections, especially not only for the fungal infections but also for bacterial infections. So today we will discuss about the management of pediatric candida bloodstream infections, case study from this Sultanul Children's Hospital.
Is the microphone, please? The microphone?
You can't hear me? Is it better? Yeah, okay. So we will start in World Health Organization published in 2020 a report on which they declared that worldwide there is 49 million cases, a number of 49 million cases of sepsis, from which 20%, almost 11 million cases of sepsis, death-reported cases of sepsis. From this, it was also estimated that almost half of it, 20 million, appear in children, especially children under 5 years of age. For every 1,000 hospitalized patients, an estimated 15 patients will develop sepsis as a complication of receiving healthcare. Sepsis also is costly. We can see that in countries with considered to be high level income countries, you will see that the average cost for a patient with sepsis is around $32,000, which is a high amount of money. Well, in the other part of the world, the situation is different, totally different. In countries with low and low middle incomes, you can see that 85% of the cases reported worldwide are related to sepsis. Also, the percentage of cases of sepsis-related deaths is very high, it's 85%. So it's really worrying. Also, in 2017, World Health Organization published a global report on the epidemiology and burden of sepsis, in which they analyzed the percentage of global death due to different causes. We can easily see here that the percentage of death, the highest, is caused by infections, and we can see that we have two peaks. Basically, one is in the early childhood, and the other one is in the elderly adults. Worldwide, incidence sepsis reported also to 100,000 persons. We can see that here we have the same situation. The income is very important because in the countries with low income or middle to low incomes, we can see that we have the highest incidence of sepsis reported to 100,000 population. In Europe, we consider that we are okay. The number is reported, it's around 270 until 340 cases per 100,000 population. Percentage of death reported to sepsis, again, same situation in countries with low income. We can see like Africa and East Asia, we can see that they have the highest percentage. Europe has a percentage of 10% of deaths related to sepsis. The University of Massachusetts published this year in January of 2024 in an article, a report on Lancet, in which they estimated the annual incidence of life-threatening mycosis. And we can see here that the most aggressive and the most common is the invasive aspergillosis, which can appear in patients with chronic obstructive lung disease, in ICU care, and also in hematopoietic stem cell transplantation here. We can see that also the second cause is the chronic pulmonary aspergillosis, and the third one is the candidemia, the invasive candidiasis. Also, the crude mortality provoked by severe fungal diseases worldwide, we can also see that on the first is the invasive aspergillosis, and on the third, and the second one is the candidiasis. Not the same, or also in September, the 16th of September this year, so a very early, fresh article, also published in Lancet. Here we can see the global time trends for sepsis, but in this case provoked by bacteria. We can see here that the things are changing, that the whole community, the whole research in the medical community realized that the global sepsis, is a global problem, especially provoked by bacteria. And we can easily see that in a 30-year period of time, in children, for example, because we saw already that the children represent a high peak of incidence for sepsis, we can see here that the incidence decreased from 8% to 3%, so which is a very good thing. Not the same, we can't say the same thing about the adults, because we can see that the incidence unfortunately increased from 3 million till 9 million. So it's not a good thing. So can we say that candidiasis represents the forgotten cause of sepsis? People forgot about it. They don't realize the importance of the fungal infections. Well, we have to take care and always think about, even if we are clinicians or microbiologists, we have to remember that the fungal infections are a really big problem. Candidemia, what does it mean? Basically, it's a bloodstream infection. It's a serious complication in children. Why? Because they have a developing immune system. They have unique risk factors. So they shouldn't be compared to adults. As the pathogens, we note that the World Health Organization stated that the Candida species are the most commonly involved, and here we have a prevalence, the highest prevalence from the Candida species is Candida albicans and Candida parapsilosis. Also, in a very small proportion, we can, aspergillosis. World Health Organization also published a report in which we can see here the incidence of the bloodstream infections provoked by Candida species. In adults, it's only 1.6%, but in children, it's 11%, which is higher. Candida albicans also in adults represents only 27% in cases of bloodstream infections instead of 48%. As risk factors, we can see here prematurity, low birth weight, prolonged hospitalization, and immunosuppressive medication. Due to those risk factors and to the incidence, which is high, 48% is not a percent that we have to overlook. We need to make sure that we have a proper diagnostic and a good laboratory evaluation. So the blood cultures, of course, they represent the gold standard. for detecting candidemia. Also, we can use microscopic examination, create smears directly from a positive blood culture, and we can easily provide the detection of candida. Antifungal susceptibility testing are also very important and crucial to be guided the appropriate treatment after this antifungal susceptibility test. As I said, due to the fact that our hospital has a specific pattern, let's say, due to all the work that we have and the high activity related to oncology, we wanted to investigate the number of prevalence of candidemia and among children, and also to characterize also the agents that are provoking this candidiasis and also the susceptibility to different antifungal treatments. So basically we investigated, we made a retrospective case study from 1 year period from the 1st of July 2023 until the 1st of July 2024. And we applied as the identification methods. We used automated blood culture systems and selective medias. As the automated blood culture systems, we in our hospital we have Bactalet system, which is created by bioMérieux. Identification was species was done on using the Vitek2 system and the MALDI-TOF. In our hospital, we have the MALDI-TOF, and for the antifungal susceptibility testing, we use the Vitek2 system and the sensitizer from demonstration. As results, we had a total positive number of blood culture analyzed of 2,384 cases. From this number, only 74 were candida positive blood culture, a percent of 3.1. Of course, when we analyzed the hospital wards, of course, the ICU was in the top 71%, followed by the oncology and palliative care. Related to the age analyzing, we can see that 32% of children that had positive blood cultures with candida were aged under 5 years old. Also, due to the fact that we have this palliative care, and we all know that as long as you stay in the hospital, the longer the period of admission is, the highest the risk of coming in contact with a fungal infection is. We had a hospital admission stay almost 3 months for 11 cases of patients. Also for 2 months, 28%, and also the majority were admitted only for 2 weeks, in a percent of 43. Okay. From these 74 candida positive blood cultures, candida albicans was the most commonly found in a 66%, compared with 48% that the World Health Organization status, and also followed by candida parapsilosis in a 31. Candida tropicalis was only 2%. As Professor Sabato from Portugal said, she warned us about Candida auris, which is a really big threat nowadays due to the resistance to the antifungal treatment. Well, in our hospital, we didn't have any Candida auris till now. As a result, regarding the antifungal resistance, well, in Candida albicans, we had a resistant phenomenon to amphotericin B, which is 42%. we had fluticasone 40%, econazole, fluconazole, ketonazole, voriconazole, and capsofungin, a small percent of 2, but a high percent for amphotericin B. In Candida parapsilosis, also we had a resistance phenomenon for amphotericin, but in a lower percentage, like 17%, fluconazole 4%. For Candida tropicalis, we had only 4% resistance to fluconazole. In 2024, the World Health Organization published a guideline for the prevention of bloodstream infection, and this guideline insisted on detecting as fast as possible the source of infection. So the source control stays as essential for the successful treatment of the patient. Also, supportive care is very important, and here we are talking about fluid management, electrolyte balance, and blood sugar control. Nutrition support, because it's applied not only for children but also for elderly persons. It's crucial to have a good immune system and to promote recovery, and some immunomodulatory therapies, which can be considered in some cases to enhance the body immune response to Candida infections. As outcomes and lessons learned, well, mortality rate in Candida infections in pediatric patients are significantly lower when appropriate treatment is provided. Early diagnostic also is very important for the outcome of the patient. Prolonged hospital stay. We know that candidemia is an infection that can lead to a prolonged prolonged hospitalization stay. As our colleague already said, there is to treat a fungal infection not only for any other pulmonary disease, but also oncological disease. It's a really challenging moment. So that's why we need to appropriate the treatment and the infection control measures to try to shorten the duration of hospitalization. Long-term sequelae, rare, but it can appear in candidiasis. And here we might talk about neurological or development issues. What we need to take care. Basically, we need for ongoing surveillance of resistant patterns. Candida auris needs to be taken in charge and to be careful about this, and also the importance of multidisciplinary approaches in the management. As a conclusion, the sepsis has many phases and can be a life-threatening condition, but it is potentially preventable and reversible. The World Health Organization said that globally, an estimated 84% of neonatal deaths due to infections are preventable. So basically, it's up to us, to the researchers, but not only, unfortunately, also the policymakers are the ones that should get involved and must be ready to force the partnership to stimulate basically the funding, because if we don't have fundings, we don't have the tools, and it's a real problem. And of course, we need to make more firmly, to put to place the sepsis more firmly on the list of critical health conditions, not only in children's case, but also in adult case. Thank you.
Thank you very much for the excellent talk. Are there any questions or comments? Yes.
Thank you for a great presentation. I'm Dr. Ali from Turkey. To be honest, I was expecting more rates of Candida parapsilosis, especially for pediatric cases. But I saw that 1/3 of your etiologic agents are actually Candida parapsilosis. So I have two little questions for that. Is there any difference, if you calculate it, I don't know, is there any difference between neonatal cases and non-neonatal pediatric cases in your study, of course? And accordingly, how many of them are actually catheter-related cases? Do you have any information about that?
All the patients that are in the neonatal in our section
Okay, thank you.
are catheterized.
And all catheterized.
Yes.
Thank you very much.
Thank you for a very interesting presentation. I'm Birgit Willinger from Vienna. You had an astonishingly high rate of amphotericin B resistance in Candida albicans, which is really unusual. Do you have any explanation for that?
Yes, it is high. We were surprised about that result also. It's 41%. We, in our hospital, amphotericin B, it's due to the fact that we have most of the patients are oncological patients. There is the first line of treatment, amphotericin B. So probably that's why we have such a high resistance. Also, as Professor Salvador from Portugal, she said she discussed a study about amphotericin B with the One Health program, and she said something about the global warming. I don't know. Maybe it has nothing to do with it, but in our countries, or in our hospital, we said that probably due to this thing that amphotericin B is written basically as first step amphotericin treatment against the antifungal, possible antifungal infection. So probably that's why.
May I ask you another question? Have you checked for any risk factors like long lines, the time of using antibiotics?
No, in our study, no, we just analyzed the antifungal incidence and not about the treatment. But it's a good point we should do.
Because you have quite a lot of a big number of cases, so it would be nice to check probably.
Yeah, they are basically the main category of patients from our study are patients that are admitted in the ICU, and as you saw already, the surgical area, the surgical pathology is the main one. So basically, for sure, they are administered antibiotics.
Okay, thank you very much. If there are no other questions, we can proceed to the next speaker. Thank you. So we proceed to the next talk by Professor Tragianidis. Professor Tragianidis, this is professor in pediatrics and pediatric oncology in the Aristotelic University of Thessaloniki.
Okay, good afternoon, everyone. Thank you, Elpina. I would like firstly to thank Professor Selinovic and Professor Vizariadis for this kind invitation. It's my second time to present a lecture in the Balkan FUNGUS, so it's a great pleasure to be here with you in Belgrade. In the next 15 minutes, we will discuss together about antifungal management of children with leukemia and those who undergo hematopoietic stem cell transplantation. As we know, invasive fungal diseases represent still an important cause of morbidity and mortality among immunocompromised patients as children with leukemias. They display constant changes in epidemiology, and as we know, although we have many newer antifungals in our armamentarium and newer diagnostic tools, it remains still difficult to both diagnose and to manage. And due to all this, we have still very high case fatality rates, especially for aspergillosis. In this slide, you can see that there is a stratification of risk of invasive fungal diseases in the pediatric setting. As you can see, patients with high risk for development of invasive fungal disease are those with acute leukemias, especially acute myeloid leukemia, recurrent or relapsed acute leukemia, like acute lymphoblastic leukemia, and those who undergo allogeneic hematopoietic stem cell transplantation. Low-risk patients with a risk below 5% are those with acute lymphoblastic leukemia, standard risk, non-Hodgkin lymphomas, and those who undergo autologous transplantation. And then sporadic occurrence, that means a very extremely low high risk for patients with pediatric solid tumors, brain tumors, and Hodgkin's lymphoma. In this slide, you can see the spectrum of disease for Candida and Candidemia in pediatric setting. So, as you see, we can have 4 different and distinct entities: the catheter-associated Candidemia, the intra-abdominal invasive candidiasis with or without Candidemia, the single-organ invasive candidiasis, and the acute disseminated candidiasis that after 3 to 6 months can become, if untreated, chronic disseminated candidiasis. What about aspergillosis? As you can see, and as we know, the most common form of disease is the invasive pulmonary aspergillosis, followed by the paranasal sinus aspergillosis, the cutaneous and gastrointestinal aspergillosis, and extremely rare issue is the CNS aspergillosis. Now we move on and we will discuss about the newer and older guidelines. The newer guidelines are written in 2019 and published in 2021 by the ESI group. The ESI group means the European Conference on Infections in Leukemia. And firstly, we will discuss about the primary chemoprophylaxis in children who undergo chemotherapy. As you can see in this slide, first options are fluconazole with the highest grading, A2, but as you know, is active only against yeast, and of course is not recommended in those patients who undergo transplantation and develop GVHD. Another option is posaconazole, also here with the highest grade, A2, but only for those children, because it's an unlabeled use in these cases, who are above 13 years of age and have more than 40 kilograms. Second options, B2, both itraconazole and voriconazole, and as we know, according to the ESI guidelines, TDM is highly recommended if possible. In those pediatric patients who undergo allogeneic hematopoietic stem cell transplantation, we have as first choice in the first phase, the neutropenic phase, immediately after transplantation, fluconazole with the highest grading, because we have many candida infections in this period. And then other options are itraconazole and voriconazole. Also in this case, TDM is highly recommended. Always in the setting of the allogeneic transplantation, if the patient develops GVHD, we have options like posaconazole for children aged above 13 years, and also voriconazole for both ages. TDM is highly recommended. What about the empirical and preemptive therapy? As we know, empirical therapy is mostly based on fever criteria, while the preemptive therapy is based on radiology findings, mostly the CT scan findings for invasive pulmonary aspergillosis, and of course the biomarker galactomannan is very important also for the use and initiation of preemptive therapy in children, as also in adults. The rationale now for empirical therapy is that we have a neutropenic child that has an absolute neutrophil count below 500 for more than 10 days, fever that persists for more than 3 days despite the use of broad-spectrum antibiotics against gram-negative and after this also against gram-positive bacteria. We have approved in children 2 agents, liposomal amphotericin B and caspofungin with the highest rating A1. This is very important because caspofungin was compared to liposomal amphotericin B. If I remember well, this was a study published in 2008, and the results were excellent for both agents. And according to this, we have now the SE8 guidelines recommendations, and as we can see in this slide, it's better if I show you, we have with the highest rating all echinocardins for empirical treatment, I mean caspofungin, micafungin, and anidulafungin, but also liposomal amphotericin B at the classical doses of 3 mg per kilogram per day intravenously. Here is a very important, to my opinion, study published in 2009 by Cordonnier, a French study about the comparison between the use of preemptive versus the use of empirical therapy. They compared these different treatments in about 300 patients, adult patients, and they found the survival was very similar in both groups. So survival was 95.3% in the group that empirical treatment was applied, and 95.1% in the group that preemptive treatment was applied. The main difference was that proven and probable invasive fungal diseases were common among patients who received preemptive therapy, and in this case we had 13 versus 4 in those patients who empirical treatment was applied. This is a very important information from the study. But the other important information is that preemptive treatment did not decrease nephrotoxicity, but decreased the costs by 35%, and this, according to the French study, was very also important. In case we have a proven infection, we have different guidelines for invasive aspergillosis. We will discuss also about candidemia and invasive candidiasis, and last but not least about mucormycosis. Firstly, we have the guidelines by the ESSI group published in 2021 in case of invasive candidiasis and candidemia. As you can see, first line are echinocardins like anidulafungin, A2, caspofungin and micafungin, but also in case of intolerance or whatever, or prior use of echinocardins, we can use, of course, liposomal amphotericin B. Also here the grading is excellent and high. Here we have the IDSA guidelines published in 2016. These guidelines focused mainly in the adult setting, but there are some points for the pediatric setting. And according to this, we have echinocardins like caspofungin and micafungin and anidulafungin as first-line treatment, but also fluconazole could be, according to the IDSA from the other part of the Atlantic Ocean, but from the USA, an acceptable alternative in case we have a low risk, let's say, for the development of invasive candidiasis patient and without who is hemodynamically stable. From these guidelines, also some other recommendations. These are the removal of the catheter if possible, as early as possible. If we consider that the catheter is the main source of the infection of candidemia, and this can be safely removed. And also lumbar puncture, a retinal examination in all children, not only neonates, but also in hematology oncology patients. All the guidelines by the European Society of Clinical and Microbiology and Infectious Disease. As you can see here, for children with invasive candidiasis, we have as first-line options liposomal amphotericin B, micafungin, and caspofungin. We move on with the SLA recommendations for invasive aspergillosis. We had the gold standard of treatment, as we know, voriconazole, approved in children aged above 2 years of age, the highest rating, A2. Another option, we have prior use of azoles, is liposomal amphotericin B. with a grading of B2. But as may you know, a couple of months ago, isavuconazole has been approved in the pediatric setting for children aged above 1 year of age, and so it was a provisional A2 according to these guidelines. Now I think I'm quite sure that will be A2 as also voriconazole. IDSA 2016 guidelines for invasive aspergillosis. As first-line treatment, they recommend voriconazole, and as salvage treatment, the lipid formulations of amphotericin B, mostly liposomal amphotericin B. What about mucormycosis? As you can see in the slides, it's very important for the management, the early antifungal therapy, the control of underlying conditions like neutropenia, use of corticosteroids, discontinuation of chemotherapy, and of course surgery, because surgery with liposomal amphotericin B, as we will see later, at high doses, is the gold standard treatment. Some older ways of treatment, like hyperbaric oxygen and granulocytes transfusion, are not grading in these SMA guidelines for children. According to the SMA guidelines, first-line treatment liposomal amphotericin B with the highest grading. And of course, as you can see in the next slide, we have isavuconazole that will be in the very near future A2 also, because it has been approved also for mucormycosis in children. And another option, second-line option, is posaconazole, or we can switch from liposomal amphotericin B as first-line treatment to posaconazole after 1 or 2 months. So in general, for the treatment of invasive fungal diseases, it's very important to have always in mind that prompt initiation of treatment is important and crucial. It's also very important to undergo radiology exams for evaluation of deep sites of infection. The source control also, I mean the removal of the catheters if possible, and of course the control of predisposing conditions like corticosteroids, chemotherapy, neutropenia, and whatever. So, the conclusions are that patients, and particularly pediatric patients with acute leukemias and those who undergo hematopoietic stem cell transplantation, mostly those with allogeneic transplantation, remain still at high risk for the development of invasive fungal diseases. Regarding prophylaxis, current pediatric guidelines recommend azole-based regimens, and always they recommend TDM if possible in our centers. Liposomal amphotericin B and echinocandins are recommended as secondary alternatives. Echinocandins are the first option of treatment for candidemia and invasive candidiasis, but an alternative could be also liposomal amphotericin B in all guidelines that we have seen. It's also important to undergo radiology examinations like the chest CT scan and to use biomarkers like galactomana for not only diagnosis but also for the monitoring of invasive aspergillosis. And last, for invasive aspergillosis, it's very important to treat the patient with voriconazole if we had no prior use of azoles. And a new alternative would be also isavuconazole, that has been approved in the pediatric setting a couple of months ago, not only for invasive aspergillosis but also for mucormycosis. And with all this, I would like to thank you very much for your attention.
Thank you very much, Professor Draganidis, for the clear and excellent talk. Do you have any comments?
Thank you for this magnificent presentation, Professor. I just have a little question, again, last year I was at a team conference, Trans in Medical Mycology, and Rezafungin was about to be enter to the guidelines, not the pediatric ones, but for the adult guidelines. What do you think about the pediatric ones? There is a good picture or good outcome for Rezafungin?
Rezafungin, you mean?
Yeah.
I know very little about rezafungin. I know that is under approval in phase 1 and phase 2 clinical trials for the same use once weekly. I don't know the results of phase 1. I know that some centers have been entered in the phase 2 studies, but unfortunately in the pediatric setting, they have no a clear picture, let's say, of the results until now. I'm sorry.
Any more comments?
Thank you very much.
Could you share your practice, in your setting, because you work at a very big oncology center, pediatric oncology center in Thessaloniki?
Thank you, Vivian. We try to follow the guidelines. This is not always possible, but actually, to be honest, we try to put anti-prophylaxis all patients at high risk, and these are acute myeloid leukemia. Actually, our patients don't undergo transplantation in Thessaloniki. They usually have to move in Athens or to the adult setting, I mean in the hospital of Papanikolaou. But actually, we try to put these patients on prophylaxis with azoles as recommended also by the newer ESI guidelines. In case it's very important, I think, we prefer to use empirical treatment, although we have access to, as Timos Misadiadis, Professor Timos Misadiadis helps us very much to galactomannan, but not only to galactomannan. In his lab we have access to glucan, PCR for aspergillus, PCR for candida. So we prefer, but although this, we prefer to start empirical treatment instead of preemptive treatment. And in case of proven infection, we're very lucky that we have a proven infection, but the patient, let's say, is unlike in this case. We go with echinocandins for candidemia and voriconazole. No, we have not used this voriconazole. Only one time we use this for patients with invasive aspergillosis.
Thank you very much. Thank you very much. So, another one.
Yes. Since the clinical treatment is so crucial to start for your patients,
Okay, thank you. Do you have any local information, epidemiological local information that you can base on instead of the, apart from the international guidelines, especially for Candida, because I know that aspergillosis is not so frequent, but maybe Candida it is. So do you have any local epidemiological information? I'm Maria Alexander from Cyprus.
Okay.
Thank you.
We try to have information. It was my last slide, but I prefer not to show this. We have an infection working group in the Greek Pediatric Hematology Oncology Society, and we published last year cases of invasive candidiasis and candidemia, mostly invasive candidiasis, so proven infections. We have a main problem, as always, in the Mediterranean region and in the Balkan, let's say, region. We have many Candida parapsilosis cases, and half of them are Candida albicans, but we don't have, in the pediatric setting, problems of resistance. So it was something like 25 cases in the last 4 to 5 years, collected from all 8 hematology oncology pediatric departments. Survival was extremely high, something like 95%, but many cases, I don't remember exactly how many, of Candida parapsilosis.
Thank you very much, Professor Tsagalidis.
Thank you.
So now I would like to go on to the third talk by Professor Marco Siroglou. Who is going to share his experience from the University Hospital of Zagreb. Thank you.
Thank you very much. And firstly, I'd like to thank you. Thanks to the scientific committee and the organizing committee for inviting me. And you're going to be hearing much of the same, dear colleagues in the chair, as my previous speakers spoke about much of the same thing that I'm going to speak about today. So I'll be talking about changing landscape of Candida species bloodstream infections in pediatric populations at my hospital. So you've already heard that population risk is immunocompromised or ICU population, especially for the pediatric populations. I won't be talking as much about the immunocompromised because my bloodstream infections that I'm going to show you from 2019 to 2024, only one of them was from a hematological ward. Most of them were, almost 99% were from the ICU ward, from the neonatal unit. So the most common species that you're going to encounter are Candida albicans glabrata, parapsilosis, and Drusein tropicalis. And you'll be seeing what is our most prominent species. Mortality from invasive candidiasis or candidemias is particularly high. It's much higher in adults than it is in pediatric populations, mind you. So it's from 7.7 to 26% in pediatric population. This 7.7% is more our Western population, Europe, Americas, and 26% is from third world countries. It's much better than adult population, it's much higher mortality in them. Guidelines that cover it for now, new guidelines are in work and I think they're going to be published soon, are from American Association of Infectologists, IDSA guidelines from 2016 and ESCMID guidelines from 2012. And you've very much heard of them in the lecture before me, so I won't be going through them as much. But prompt initiation of antifungal treatment is of paramount importance, and identification of species, if possible, of course. And you should always treat any and all underlying conditions. That's much harder to do than to say. And of course, you should continue the therapy for particularly long time if you're comparing it to therapy for bacteria. It should be continued for at least 14 days after you have negative blood cultures. Antifungal therapy that's most common and is given is echinocandins. So caspofungin and microfungin are listed here. Anidolafungin is not listed here because at the writing of the guidelines it was not approved by FDA or our European agency to use in pediatric population. As of its approval, it has the same rating as caspofungin and microfungin. Liposomal amphotericin B, I would like to highlight that because you're going to see that most of our patients use or get liposomal amphotericin B because of our Candida species that is most prevalent. And of course, I wanted to note this hematogenous Candida meningoencephalitis because I'll be giving you a note on a case that was presented like this, why we changed our initial antifungal therapy like in 2008, so 16 years ago. This is the hospital that I work in, and diagnostic tools that we mostly use, or that I'm going to showcase here, are blood cultures, so PD-BACTEC culture bottles for aerobic and mycological samples. And I'm going to be showing you the question from Turkey that was catheter-related candidas. Most of the bloodstream infections are catheter-related, so I've put from 2019 to 2024, I'll be showing blood culture results, but I'll be also showing catheter isolated Candida species. Mostly in neonatal units, we use big catheters. These are peripherally inserted central catheters, so they're a little bit different than central venous catheters that you use in adult population mostly. Identification of species is done by normal microbiology, sub-row agars, chrome agars, and biomaltitol. I just wanted to talk about some alternative tools. So this is a definite diagnosis. If you have a blood culture positive for Candida and you isolate it and you identify it, you definitely should treat it. You must by all guidelines. But if you don't, and you have a, I don't know, febrile patient or a patient that has high CRP or perhaps procalcitonin, but mostly CRP, you have some alternative tools that could help you. Fish is not an alternative tool to this what I'm talking. Fish is used to quickly differentiate when you have growth of Candida, so you can see what Candida species it is, so you can give them the best treatment possible as soon as possible. So betadine assay is mainly used in adult population because it has cutoffs for adult population, but we still use it in pediatric population. We know there are no cutoffs, but if it's extremely high, it's highly probable that you have a bloodstream infection by Candida species. And if it's not extremely high, let's say, I don't know, 100 range, then you can still use it as kind of a diagnostic tool with clinical evidence. And the third one is Candida score. I wanted to highlight that because it kind of mitigated the use of beta-glucan assay that we implemented in 2019 at our laboratory. It was mostly used at first to see if there are possible Candida infections. After the implementation of Candida score on all our ICUs, it's mostly used as a let's see if our therapy is working tool, and not let's see if somebody has Candida BSI. Because if you have a difficult patient and Candida score is over 3, I know it's over 2.5, but let's be honest, that's 3, we're giving him antifungal treatment. So the data I'm going to present is from January 2019 up to August 2024, and you'll be seeing positive blood cultures with Candida species that were isolated, and positive central venous catheters or peripherally inserted central catheters, mostly RPICs. The numbers are, let's say, smaller than you've seen in colleague from Romania's lecture, but those are because I didn't count positive blood cultures, but only specific patients. So these are the findings, and I would like you to take note of the red one and the light blue one. Light blue one is Candida albicans, and the red one is Candida parapsilosis. As most of you know from Balkans, Candida parapsilosis is the most prevalent species of Candida in our hospitals. Nobody's bad guess that it's in our hospital as well. This is the percentage of Candidas, which is, I think, more important than the actual numbers, because this is what drives your empirical treatment of Candida bloodstream infections. So in 2019, the surge of Candida parapsilosis in our hospital actually started earlier. I was thinking about implementing the beta-glucan assay positive samples which were positive for chemocultures, but I decided not to, so that's why the research or the data I'm showing you is from 2019. It would be for 10-year period if it were only this initially. Candida parapsilosis surge started in, I don't know, like 2015, 2016 at our hospital, and it was the most prevalent species in adult population, bloodstream infections, and also in pediatric population till COVID hit. When COVID hit, we had much less admissions at pediatric units, much less Candida infections by Candida parapsilosis, and it was mostly due, in our opinions, due to more staff available, because most of the normal wards were closed for non-essential patients. So the hematological ward and the ICU ward got more nurses. And the most common theme around Candida parapsilosis is an intra-hospital Candida. So you get it from horizontal transfer / from ward contamination mostly. And that was kind of mitigated during COVID. So that's 2020, 2021. And in 2022, things were starting to get normal. in pediatric wards, and you have again a surge in Candida parapsilosis, and in 2023 it followed, and in 2024 the only isolated bloodstream infection of Candida patient who had it had Candida parapsilosis. As a note, I would like to also say the yellow one in 2019 is Candida lusitania, and that's important because the therapy we give. As for susceptibility, I didn't put it, but as a previous speaker from Greece said, Professor, most of our Candida are sensitive to everything. So even Candida parapsilosis, which in our adult population I think has a resistance rate of azoles nearly 90%, in pediatric population is almost exclusively sensitive to azoles. So fluconazole is sensitive as well as voriconazole for Candida parapsilosis in pediatric population. We had one Candida parapsilosis in pediatric population that was resistant to fluconazole, and I think the trend might continue because all the other wards in our hospital have the resistant type. So it's bound to happen that it's going to come to the pediatric wards as well. Candida albicans is of course sensitive to almost all, and I mean all our Candida albicans are sensitive to all antifungals. Why I'm highlighting Candida lusitania, because in vivo you can give amphotericin B for that infection, and most of our patients in that year, apart from that one, had Candida parapsilosis, and our first line treatment for Candida parapsilosis is amphotericin B. So that patient was empirically treated badly. And as for catheters, I'm just gonna skip to the percentages. So these are the distributions for catheters. Most of them, all years, apart from 2021, where albicans takes the cat by one, are Candida parapsilosis, which I think everybody expected, because Candida parapsilosis is mostly hospital Candida and is mostly isolated through catheters. So most of these catheters had bloodstream infections linked. So you have one Candida parapsilosis here in 2024. It was isolated from a catheter as well. Only 2 catheters had Candida albicans as well, and 2 catheters more had Candida parapsilosis but didn't have verified bloodstream infection. Of course, these bloodstream infections that I was showing you were symptomatic. They were invasive candidiasis. Those patients had verified sepsis. And that would be all for me.
Thank you very much for the excellent presentation, clear data. Are there any comments, any questions?
In 2020 and 2021, you cannot say the wear of gloves can be a factor
for less Candida parapsilosis,
Yes.
you're asking that. Let's put it like this, wearing gloves, I don't think that would be a factor, because mostly our nurses disinfect hands and don't, I mean, when you're doing catheter related stuff or any blood related stuff, you have gloves nonetheless. Actually, if you wanted to ask about personal protective equipment and COVID, I don't work only with mycological samples. I mainly work as a consultant physician at wards, so most of my work is clinical, and I've worked for 3 years at COVID wards and COVID ICU. We had a major surge in intra-hospital pathogens because of personal protective equipment, so it isn't as much that it helped mitigate horizontal spread, it facilitated horizontal spread. So I don't think that's related.
Okay.
I'd like to ask all the presenters if anyone has any data can answer. So there is a recent paper of Professor David Denning, you all know, I believe, telling that among all invasive candidiasis cases, only 40% of them are positive, has blood culture. So, but I don't know that this is also very valid for the pediatric cases because they're all generally catheter related, or maybe this rate can be a little bit higher. But do you have any ratio or any data about that? Maybe they can tell about their personal experience, I don't know.
Well, I'll try to answer. I'm not the expert on the field, but I'll try to answer. So if we're talking about invasive candidiasis, I'm not so sure. If we're talking about candidemia as well, definitely. Because if I show you the raw numbers more closely, you'd see there were more candida species isolated from catheters than there were bloodstream infections by candida. So those species that were on catheters, those certainly were in the bloodstream. They just weren't in enough capacity to have an infection.
I would like also to comment on that answer. Let's say unofficially, I don't have any data, but as on my experience, I'm sure that we lose too many candidemias. I mean, to be proven by blood cultures. But as soon as we have high risk proved, especially by multifocal colonization, it's a very high risk factor. And in combination with immunocompromised clinical other findings, I think we should consider a patient that may have candidemia without having positive blood cultures. After my experience.
Yeah, of course, I definitely agree. So if you have multifocal colonization, like
I
two or
like
more
very
sites.
much the score that you showed, the table with the score. I think that it's very good table to base on that to start a medical therapy.
Look, I don't know how any of the other hospitals do it. I mean, I know about quite a few of them, but the normal thing why you're even doing surveillance is not that you can, I don't know, separate the patient from the others, that you don't have horizontal transfer, but you're doing it so you can guide the empirical therapy. So that's why we do it at least once weekly, our colonization swabs, so we can see what kind of species the patient has. So if he develops or she sepsis, then you can promptly give it the right treatment. And most of our patients, of course, as was already asked, are on a wide spread antibiotics. So most of the pediatric ward ICU patients receive meropenem and vancomycin. On meropenem and vancomycin, and we don't have carbapenem-resistant Enterobacterales in our ICU pediatric wards, you have a febrile patient or a patient that's unwell or in sepsis, you should definitely give him an antifungal agent.
Thank you very much. I think we have come to the end of this session. And we can go on.
First of all, I would like to invite from Romania, Dr. Yulia Baja, if she's here. Well, it seems not, so I'm going to introduce this session. So, there's a good and bad news. One presenter is missing due to health conditions. This is the bad news. And good news, it seems that we are up to date and we will manage to be on the time for our lunch. So now I would like to, the data we are going to probably miss is epidemiology of dermatomycosis and onychomycosis. As we heard, there are about 5% of the patients in Europe that are having this disease. So each 20th patient is coming to the dermatologist. Now, we've seen a lot of data presented here from the laboratory view. But now, in front of us is Professor Snežana Linić, who is working on the front line with the patients, like we together work. So she is one of the persons that is telling that the person should undergo laboratory investigation. And this is the story from the perspective of a clinician. So let's hear him talk.
Well, hello everybody, thank you for inviting me over. And this will be from the angle of dermatologists. So I do apologize if some species are omitted, but I'm just giving the example, how do we think and approach the problems with mycosis, at least in dermatology and everyday practice. Let me see, epidemiology. I'm not going to put too many facts about it, like fungal skin, nails, and hair infections are called all superficial mycosis, and they're very present all over the world, including this part of the world, talking about Balkans. These are some of the statistical data which I'm not going to stay with any longer. When we talk about the classification, then we of course talk about superficial and invasive fungal infections, which is the most common superficial infection, is pityriasis versicolor. A lot of people don't even consider it as an infection, but as a status. They even think it's inherited. To be frank and truly speaking, some people do inherit the type of skin which is more susceptible to this kind of species, and therefore it runs in a family, but it's not hereditary though. Dermatophytosis are classified into three genera, as we see: Trichophyton, Microsporum, Epidermophyton, and these fungi, what is very important, are keratinophilic. They like keratin, they like keratinocytes. And then, depending on the depth of the infection, we have another classification. And this kind of classification, it's not too much classification, it's more like memory shells or memory drawers from which you actually pull out the data that is already in your mind. So superficial fungal infections and deep fungal infections, that's something what we have to think about, especially because of the treatment that we're going to offer, and some diagnostic procedures as well in these cases. The most common, deeper one is carrier, especially we're talking about children under puberty, and for instance, Meiocchi granuloma. Classification of origin is another kind of classification, and then we have these. That's of course very important to bear in mind when we talk about epidemiology and the pathway of infection. Therefore, we have to think about anthropophilic, zoophilic, and geophilic infections as just to give good advice to these people how to behave once that they leave our office. When we talk about the full diagnosis, TINA is most popular way of putting diagnosis of fungal infection, and it's easy. Everybody easily remembers it. So TINA would be the first name, the family name would actually define the site of the body that is infected. And therefore we have TINA capitis, barbifaciae. I'm not going to read it anymore. Diagnosis of superficial fungal infections is still very cheap and available almost everywhere. We have to have, as we call, scarificate. We have to take a little bit of sample of the affected or suspected area, and then we add potassium hydroxide to get rid of keratin, and that's called this native examination. Culture is also, of course, important. Then we can do histopathology, then we can do PCR, then we can do spectrophotometry. And this is just to give you an example how cheap this could be and how easy to do in practice. You have to do the sampling really thoroughly and in a correct way? That's another question. A lot of times it could be false negative, because you were the one who was taking species was, you know, in a way, he felt sorry for the patient. It will hurt him or hurt her. That's not the way to do it. Do it in a proper way in order to help this person. Then you, of course, add potassium hydroxide, and what do we get? This is one of the native samples, which even we dermatologists can detect. That's the presence of spores or the presence of hyphae. Hyphae are quite often arranged in what we call spaghetti type of arrangement. I'm not going to spoil your watch, I hope. And then we have cultures. The situation with cultures is more or less the same everywhere in the world. It doesn't necessarily have to be positive, even if you have the positive native. You know that more than I do. Wood lamp is another diagnostic tool which we use, but not only to detect the fungal infections of our body and appendages. We use it in other cases as well, and certain species have certain color that helps us a lot, and it also helps us in following these patients for the follow-ups. Tinea capitis, of course, affects scalp and hair shafts, primarily seen in children. Why? Because of the function of the sebaceous glands. They are not fully functional until the puberty, and we don't have this lumbricoid protection. It goes not only for folliculus, it also goes for the skin. So that's why we see it more frequently in children, and the most common causes in Europe are Microsporum canis. It also tells us that these species are zoophilic and very often come from the pet animals, either cats or dogs. This is the Tinea capitis, which we usually see, and of course, although I was stressing this lecture or presentation to superficial ones, we have this gray patch tinea and black dot tinea. That's important to bear in mind because it could be confused or misdiagnosed with other types of alopecia. So whenever you have alopecia among children, do check for the presence of fungal infection. And then of course we have deeper carrion, which is, as I said, quite common among children, especially these zoophilic Microsporum canis, and FUNGUS, which I hope it's more or less eradicated in majority of Balkans, but was present until the 1945, I guess, and there was a traditional way of treating these patients with X-ray. Recently, I saw a lady who was a baby at that time, and she was a small girl, and she was treated with that, and of course, the result was cicatricial alopecia. Tinea capitis local treatment. Local treatment preventive measures. It's hair cutting or pulling out the hair, topical antifungal creams or antifungal shampoos, and of course, we do have to go to systemic therapy. The best would be to start with griselfulvin, and then etraconazole, terbinafine, fluconazole,